we have with us Dr. Kinjal, who's a radiation oncologist at HCG Ahmedabad. We have our thoracic surgeon, Dr. Harshvardhan.
Good evening. Good evening, everyone.
Dr. Suryakant. I don't see him.
Dr. Suryakant sir is just joining. He's having some technical difficulties at his end. He'll just join shortly.
All right. So shall we start with the case then?
Yes, please.
Shubham, yeah, back to my screen. So we'll be discussing, taking forward what Dr. Balaputhish just said. We just have a practical experience with the same. We have a patient who was a 59 years old male who presented to the OPD with complaints of loose motions, anorexia, dyspnea on exertion, which was worsening since 15 days, upper backache, which was controlled on medications but worsening gradually. He didn't give any complaints of, didn't give any history of complaints of headaches or any bony pains. In personal history, he was a smoker, average 3-pack years, alcoholic since 30 years, diabetic, hypertensive, GC was average, COPD status was unknown. He presented to the OPD with an MRI spine, which showed a large mass in the right lung upper lobe extending into the mediastinum with involvement of T1 nerve root brachial plexus. It was encasing the right divisions and cords, probably explaining the pain. Dr. Harshvardhan, what would be your next steps for workup of the patient? Generally, such kind of patient presents to the surgeons.
If this kind of patient presents to me, the imaging modality present, which is present with the patient, I will evaluate that imaging modality, whether it's a CT scan or something. If the patient is having a detailed CT scan, I'll discuss it with my radiologist, and then go for something which will give me more insight in what the diagnosis is and where I can biopsy that patient. So my next step would be to get a PET scan of that patient.
So in such cases where there's a high suspicion, you prefer PET CT before getting biopsy done?
Yes, yes.
Okay. So we had a PET CT done, which showed a metabolically active large mass in the apical posterior segments of the right lung upper lobe. It was eroding the second rib, D1, D2 vertebrae, attenuating the bronchus. Apart from that, there were multiple metabolically active infiltrates in both the lungs, plus metabolically active mediastinal nodes. A CT-guided biopsy from the active part of the mass was done, which showed poorly differentiated carcinoma, which favored non-small cell lung cancer. So, Dr. Nilendu, you have the images. What would be your interpretation?
Okay, can you hear me?
Yeah, we can hear you.
Yeah, so there are these 3 sections of fusion PET CT scans which are provided, and there is a coronal fused PET CT which shows a large FDG avid mass, in the upper lobe of the right lung with a central area of cavitation or necrosis. As you said, it seems to be involving the superior sulcus or the lung apex or the thoracic inlet, and I can't exactly see the bone windows, but it seems to be involving the paravertebral region. But since the MRI also showed that, I would presume that it's involving the paravertebral region. So there is an extension into the extrathoracic space. There are some FDG avid mediastinal lymph nodes also, probably N2, and I can see some FDG avidity on the contralateral side as well. So probably this makes it a definite T4 N2/N3 lesion. And I can see, some tiny nodular opacities, as you mentioned in your findings, bilaterally, but it's difficult to, characterize what they are. We need a detailed kind of a evaluation of the CT scan. but few of them look to be kind of endobronchial branching opacities. But here I am not very sure whether these are bilateral lung metastases or whether these are just post obstructive changes in the lungs, like post obstructive bronchiolitis. I'm not very certain, but these two would be my differentials for the lung opacities.
So you will keep metastatic nodules as one of the differentials in this case.
I would have a very close look at the CT chest component. We, in our PET CT protocol, we do take a breath hold dedicated CT scan of the chest with high resolution, precisely for this reason, because if you have these tiny nodules with coexisting infections, we really need to characterize them properly. And here PET really doesn't help if the nodules are very tiny. We really need to look at their characteristic CT appearance. So very often infections, or particularly in centrally situated lung masses with hilar lymph nodes, there can be blockage of the airway, and we often do see post-obstructive changes in the lungs also. But yeah, I mean, METs would also be a DD, simply because I'm not able to see it very clearly on this particular scan. But I leave it to you how you have characterized these and go by that.
Yeah. So just to proceed with the case, there were no left hilar nodes. There was only a hilar node on the right side. The subcarinal node was also not avid. So
Okay.
Should we still suspect obstructive bronchiolitis on the left side?
If you're saying that there was nothing which was kind of blocking the airway, there was no big subcarinal lymph nodes, though I can see some soft tissue. But then in that case,
there is a subcarinal that's not avid. There is a subcarinal node.
So there is kind of whether it's not avid, but there is some kind of compression of the airway. Then this also would be something at the back of my mind. But I guess your entire treatment hinges upon what these nodules are. We are quite clear about what is the T stage and what is the N stage. So I mean, these two would be my only infection or post-obstructive changes versus metastases. So I leave it to your expertise to kind of.
So would you advise any other further investigation to actually characterize these nodules, because they will change the entire management?
It's only the HRCT or high resolution imaging of the lungs, or probably an FOB and or a lavage or something, if it kind of shows up some infection or something like that. But beyond that, beyond imaging, I don't see any other, beyond the PET CT or a CT chest, I don't see any other imaging which can resolve this this issue.
Yeah. The burning question: how much do you rely on the SUV of the mediastinal lymph nodes to say them that they are involved?
Involved by malignancy? Okay.
By malignancy.
So we actually, there have been several papers, or there's a lot of data and literature which have come at various cutoffs. Even we have in our experience certain SUV cutoffs, but honestly, FDG uptake really doesn't get you anywhere. An FDG avid node can very well be infectious or granulomatous or tuberculous. So, and there is a significant overlap in FDG uptake of tuberculous lymph nodes and malignant lymph nodes. So I really do not rely on the intensity of FDG uptake seen visually, or even which is quantified in terms of SUV to decide whether the node is definitely malignant or no. We usually go in for some kind of an histopathological diagnosis, either by EBUS or TBNA, and eventually, if not, then by mediastinoscopy.
And anything just on CCT which can suggest about the characteristic of the mediastinal lymph nodes in particular?
So very often on CT, people say that if you see necrosis, then it's more likely to be tuberculosis, but you do see necrosis even in squamous cancers. So that's really not very helpful. What we have found useful is, a definite evidence of calcification in lymph node. if the node is densely calcified or if it has a significantly high Hounsfield units, they are more likely to be granulomatous irrespective of whether there is FDG uptake or no. From our own database of around 400 patients, when we have used the criteria of calcification or Hounsfield units, the specificity of PET has jumped up by around 20%. So presence of calcification or a high density of the lymph node on CT scan, improves the specificity of PET scan. But other features, if the calcification is not there, then merely presence of necrosis it can't really, differentiate between a malignant or a tuberculous lymph node.
Dr. Harshvardhan, question for you.
Um,
How much do you rely on FDG PET-CT for initial staging in the lung cancers, suspected lung cancer?
Just to give the thing that we see whether the nodes are lighting up or not. So we divide it into PET positive or PET negative. If the nodes are lighting up, then we definitely go for some histopathological diagnosis by the way of an EBUS or a mediastinoscopy or whatever means we think are possible. Because in practice, we have seen that our data of 137 patients, which has been analyzed by one of my PGs, it has been seen that 9.2% of the nodes were tubercular, and the false positive rate of this PET scan turning out, we thought that it would be malignancy was something like 18 point something percent. So there is a lot of this false positivity of we thinking that this node would be of positive because of its ability and lighting up, and it turns out to be a tubercular or some infective pathology, particularly in Indian scenario. So we always go for a histopathological diagnosis in PET positive nodes.
Dr. Kinjal,
Yes.
to you. So what next? What would you like to do next? Any other investigations, tests?
No, I think majority of the tests are done. We would just do because this is a patient who will be going for chemotherapy. So I think we would just do a pulmonary function test and maybe a echocardiography just to know the status fitness of the patient to put him on chemo.
All right. So this patient, as of now, he's a candidate for chemotherapy.
Yes.
Any role of radiation in this patient?
No, I don't think any role of radiotherapy in the beginning right now. But if the patient's pain is too much because the T1 nerve roots were compressed, we can think of a palliative radiotherapy for pain relief. But I would not be too keen to do it because let the chemotherapy work. If it is not working, maybe after 2 cycles and pain increases, then we can think of radiotherapy at that time. So I would definitely refer this patient to my medical oncology colleagues.
Okay, so that was the same thing which was done here as well. The patient was referred to the medical oncologist, and he received 3 cycles of chemotherapy with pemetrexed plus carboplatin plus Avastin. So after 3 cycles of chemotherapy, the mass showed a significant reduction in size and FDG avidity. The nodular infiltrates which were there in both the lungs, they had disappeared. The mediastinal lymph nodes actually increased in FDG avidity. Apart from that, there were some non-specific nodes in the left cervical regions as well. So this was the scan after 3 cycles of chemotherapy. The mass showed a very good response, and now we can see a subcarinal node which is actually lighting up. Dr. Nilendu?
Yes, you are seeing a lymph node there in the subcarinal lesion. You can see that the mass has significantly regressed, and even the lung opacities have significantly gone down. It's kind of an indirect proof that they probably were metastases and have responded to chemotherapy.
So that was our final conclusion as well. So what all are the response criteria that you use for patients on chemotherapy?
So, I mean, you have you can use, there are several response criteria defined in literature. You can just go by visual criteria. You can use your SUV max, where you can use the EORTC criteria of reduction in SUV by around 25 to 30% classifies it as a partial response. You can use the PERSIST criteria also. We do not per se mention a specific criteria, but we just go by subjective and kind of a visual evaluation first. And we also look at the percentage drop in the SUV. And this definitely amounts to a partial response.
So, because we labeled this patient as N2 earlier, would we still stick to that considering the mediastinal nodes have actually increased in avidity?
So, that's it's kind of that raises the question where you have lung nodules which have regressed completely. You have such beautiful regression of the mass, but the nodes have actually progressed on chemotherapy. So, whether it brings us to the question whether we are dealing with a coexisting infective or granulomatous pathology where often after initiation of chemotherapy, when the cancer regresses because of immune suppression or something like that, the infective changes which are coexisting probably flare up and are become more prominent on imaging. We see this quite often. So there is this possibility also now, because some mediastinal nodes have definitely gone up. But you can, the pre-existing nodes in the precarinal region, those which were there, they have kind of
Gone down.
Yeah. Some nodes have gone down, some nodes have gone up. So I'm not very sure whether this is a kind of a differential response or we are dealing with a coexisted granulomatous pathology, which is now flared up after chemotherapy. So these two possibilities remain.
So, Dr. Kinjal, if we disregard the metastatic nodules, if in such kind of a patient, if you would want to take the patient for a definitive radiotherapy, how do you go about the mediastinal nodes in such a scenario where some have increased, some have decreased? What would be your next step?
Yeah, so this is a common scenario which we see for our head and neck patients also. The head and neck patients present with a mediastinal node, or maybe a lung or an esophagus patient with mediastinal nodes. And just like what Dr. Harshvardhan had said earlier, we would definitely prefer doing EBUS guided biopsy and or a mediastinoscopy and prove it whether it is a positive node or not. As far as the radiotherapy for such a patient is concerned, earlier having nodules of lungs gone, I don't think is a candidate for radiotherapy. But if there were no nodules in the lung and the patient presented only with a T4 tumor and the mediastinal nodes, and the way the response is seen, this patient can be taken up for concurrent chemoradiotherapy. I mean, if the nodules are not there. So if it was only a T4 and 2, yes, we can treat this patient with radical chemoradiation. But I would again, looking at the picture, the middle picture, I would still feel that we can do an EBUS and try to find out whether this node is positive or not. Because now when we do radiotherapy planning, we do a PET-based radiotherapy planning for majority of our patients at big centers, and we treat only what glitters. Actually, the name of the scheme is also matching, because earlier we were treating the nodes in a big chain we were treating. Now we only treat the nodes which are involved. So for me also, just like a surgeon would like to know if the node is positive or not. So I would prefer doing a mediastinoscopy, EBUS, and see the nature of that node.
So apart from lung cancers, which other malignancies would you prefer doing an EBUS before treatment?
Head and neck, because I see a lot of head and neck patients. In Gujarat, we see a lot of tobacco chewers and smokers. So we see a lot of head and neck malignancy, and they do present on a PET with the mediastinal nodes. And we have burnt our hands. I'm talking about 15, 20 years back. We had a patient, and patient had to go to Tata for a PET CT, got a PET CT done, and it was showing mediastinal nodes. Patient was offered palliative chemotherapy. After 3 cycles, primary was gone, and the mediastinal node was still there. And then we thought, we burned our fingers. We wasted the patient's time for 3 months. Then we got a mediastinoscopy. Biopsy was showing tuberculosis. So for head and neck, it is a highly suspicious that it may be not positive, maybe a granulomatous or an infective node. Yeah.
So Dr. Nilendu, which mediastinal lymph nodal stations would raise more suspicion for a malignancy and which will raise more suspicion for being just granulomatous?
It's actually more of a theoretical thing, but you can get tuberculous nodes all over the place. Usually, in what we do say, as Kinjal said, in head and neck patients, we often see them in the right 2R and 4R regions. You often see lymph nodes in that area. There is a certain pattern described, bilateral, hilar, paratracheal lymph nodes. When you see a classical PET pattern, which is like, bilateral hilar nodes you have in the right paratracheal stripe. Very often in our experience, when a EBUS or mediastinoscopy is done, those turn out to be granulomatous. But I wouldn't say there's a very hard and fast rule that from the location we can be certain that certain location would be because of malignancy and certain locations would be because of granulomatous disease. EBUS, some kind of an histopathological correlation would definitely be warranted. As he said, we have also burnt our fingers. We have tried everything possible. We have tried SUV. We have tried using CT criteria. We have tried to take ratios. Nothing seems to work out very definitively in characterizing mediastinal lymph nodes. It eventually has to go for some kind of histopathological evaluation.
And as I understand, like we have also experienced, there's no correlation of the SUB of the primary with the SUB of the mediastinal nodes. There's no.
Nothing works.
Nothing works.
Dr. Jaspriya, you have 3 minutes with you.
Yes, ma'am. So the patient was continued on the same chemotherapy. He came back with multiple bilateral lung infiltrates, there were some consolidations which were as FDG avid as the primary mass. So Dr. Nilendu, what will be your differential now?
This is a really foxing case, but if I look at the lung windows, I can see a VY tree bud kind of a pattern in the in the lungs and kind of an endobronchial disease spread. So I would with lymph nodes increasing and these kind of opacities, I would really try to prove or disprove a coexisting tuberculous infection just because of the pattern of those lung changes which are happening there. Because anyways, if these are metastases, we are not going to do much further change. But if it's an endobronchial TB, then he really can be treated for that also.
So we have the differentials with us. The patient was subjected to a biopsy. It came as necrotizing granulomatous inflammation, and the patient was referred to pulmonologist. So my question would we like to restage the first scan?
Yeah, ideally we should.
I think so, yeah.
Yeah.
What could we have added to the workup, or
maybe the EBUS done at the beginning. EBUS at the beginning would have definitely helped.
First scan in EBUS.
Yeah.
this would have been for mediastinal nodes? Anything for the lungs? I mean, or we would have taken lungs just as tubercular.
No, I think with a very doubtful picture in the lungs, I would have gone for a very diligent mediastinal staging. If few of them would have turned out to be tuberculous with this necrotizing granulomatous infection, then it changes the entire picture and staging. Then probably we would have not looked at the lung nodules so critically as malignant, and and would have changed our intent of treatment completely.
And Dr. Kinjal, does it change the intent?
Yeah. So to begin with, if we had proven that it was a tuberculosis, we would have definitely given neoadjuvant chemo first. Like we would have started with chemo only. Maybe after 3 seconds with an excellent response, we would have gone with the chemo radiation at that time. Yeah.
So Dr. Harsh, last question. So do we do EBUS in all the patients?
So all PET positive mediastinal lymph nodes should be subjected to histopathological examination. The first step for a thoracic surgeon is to go for an EBUS where it is available. The availability should be there and expertise should be available. They should station at least, they should sample at least 3 stations in all the cases. If the expertise is not available, if the EBUS thing is not available in your hospital, then go for a mediastinoscopy and stage the mediastinum. But all PET positive these lesions should undergo some kind of staging, some kind of modality to be staged.
So we just can't take it on the face value. That
No, not at all.
I'm Dr. Charu. So